So, plan today, we'll go through blood gases, analysis of blood gases, and what we're going to consider is the metabolic aspects of acid-base balance versus the respiratory aspects. And this is the graph that is on the first page, and it's really an expression. It's really an expression of the Henderson-Hasselbalch equation. There are many ways you could express the Henderson-Hasselbalch equation, but this is the way that Costanzo does it graphically. When you take step exams, they may use different graphic representations. Instead of plotting what we've got here, PCO2 against bicarbonate, it might plot acid against bicarbonate, all sorts of things. But let's just use this one. And yes, sir, ma'am. I'm sorry.
I don't think your mic's on.
Well, it says it's on. Okay. Can you figure out what I've done wrong? I can. See if you're as... Is it the mute? You found the mute? Okay. Somebody had flicked the mute. There's a mute toggle switch. We're good now, right?
Yes.
Good. So on this particular plot, we're plotting PCO2 against bicarbonate, and you might predict if you plot PCO2 against bicarbonate from that equation, then pH would be a straight line. Okay, so we have pH lines that go like so. Make sense to you? So the normal, this is my red pen, by the way. This is technology. The red pen is painting black. So this is normal, around 25 for bicarbonate, around 40 for PCO2, and that would be a pH of 7.4. Okay, let us work to change acid-base status. First of all, let us just do, let's have a respiratory acidosis. How would we do that? What might cause a respiratory acidosis?
Overdose.
Overdose of opiates, yeah. And certainly nowadays that's something you probably ought to know. So all of a sudden, let's pop one of those pills. We'll tend to migrate up this way. And I'm going to end up here on a line pH 7.22. And you will notice that the bicarbonate's gone up a little bit because we've slowed our breathing, we've generated more CO2, which has made an acidosis, but also the bicarbonate went up a little bit too, just a little bit. Now, the kidneys, over a period of a day or so, can now compensate for that abnormality. And under normal circumstances, they will. And so, what the kidneys will want to do is add bicarbonate. Okay? So if the kidneys can add bicarbonate, it'll mop up this excess acid and go in this direction. So we'd go in that direction. The terminology that we've used here is acute, that's immediate. I mean, if we just stop breathing all of a sudden, that's where we go. But if the kidneys are functioning properly, after several hours, day or so, whatever, in chronic conditions, there will be a compensation. And now the pH has gone from 7.22 back to 7.3. It hasn't gone all the way back to 7.4. And I want to be sure that we use correct terminology. This is not a correction. The correction would be to fix the respiratory problem, yes? This is a compensation. And so understand that what we've done is we've got a defect, and the kidney smartly generated a similar defect in the opposite direction. Compensation. So all they really fixed was the pH. We got derangements in both the respiratory system and the metabolic system. But since they're opposite, it'll at least, I don't want to use the word buffer, it'll at least ameliorate the pH change. Okay? So that's compensation. So let's do something different. Let's have a metabolic acidosis. So now we're adding acid to the system. And I bet you respiration can compensate. Oh, wait a minute, I don't have anything here. So metabolic acidosis, basically take bicarbonate away. We'd go in this direction, right? But I don't see any shaded parts over here. Why is that? Well, if everything's working well and we get a metabolic acidosis, the lungs can compensate. How quickly can the lungs compensate? Pretty darn quickly. If I chug-a-lug some hydrochloric acid, my respiration could keep up with it, right? I mean, so it's a matter of seconds. So in this particular case, the compensation actually occurs instantaneously. So if the respiratory system's working well in a metabolic acidosis, you'll basically travel directly down this line here. Okay? See if there's anything else I want to add. No, that's probably good. Okay, so I think the next part's the easy part, next page, page 2. So now we want to know if we can use this to analyze acid-base status. And clearly, you guys, you can all see a change in pH, but you've got to be pretty discriminating and figure out what's causing the change in pH. And the first thing you need to know is whether it's the respiratory system or whether it's the metabolic system that's changing the pH. Of course, you don't want to be correcting the compensation, do you? No. Okay, so let's look through the steps. I've broken this down into very easy steps. And I've got step 0 because before we start blood gas analysis, we're going to be, basically taking the history of the patient, trying to figure out what might be wrong. So if we decide we've got an acid-base disturbance, first of all, we're going to take a blood sample, preferably an arterial blood sample. Very often it's capillary blood. And capillary blood's pretty good for PCO2 and pH. It's a little more dodgy for PO2, but for the most part, at least as far as the PCO2 is concerned and the pH, we can get pretty faithful readings. Understand, and I said this the other day, we measure pH, we measure PCO2, and the only unknown in the equation is bicarbonate, so the bicarbonate that's reported is a calculated value from the Henderson-Hasselbalch equation. Yep. Okay. All right. So let me let me get rid of this screen. Get some lights back on. So in very simple terms, the simple steps. So pH, first step, pH. Is it acid or is it alkaline? And that will quite simply come from the pH, okay? Next step is you can measure you look at the PCO2 or the bicarbonate. Which way do I have it listed here? Probably both at once, right? Okay, both at once. All right. So, first of all, let's look at the respiratory component, the PCO2. Okay, and again, if the PCO2 is above 40, it would be tending to make acid, yes? Okay, and so I'll just do the same thing here, acid or alkali. And you can also look at the bicarbonate, HCO3, and again I'll say, well, if the bicarbonate's low, that would tend to be acid. And if it's high, it would be alkali. And some of you are looking at this and saying, well, it's more confusing than that. But it really isn't. Let's use some real numbers. And I think, let's use, I've got some numbers below, 7.22, PCO2 of 28, and bicarbonate of 11. Let's see if we can figure that out. So, 7.22. Well, that's acidic, isn't it? What's the PCO2? 28. Alkali, right? What about the bicarbonate? 11. Acid. Okay, so what have we effectively done here? And let me qualify it by asking some idiot simple questions. Could the respiratory system have caused the acidosis? No. Okay. Could the metabolic system? Yes, it could. So in other words, what we're looking for is whatever the pH is doing, what matches the pH. Okay? And in this particular case, we've got an acidic pH, and the only thing that's looking acidic is the bicarbonate. So in real terms, if we look back at this, here's the 7.22, remember? Where was it? Never mind. I'll come back to that. So pH of 7.22, it's a metabolic acidosis. So what's going on here? It's the compensation, yes. And so if everything's working well, this is a simple problem where you have metabolic acidosis with probably appropriate respiratory compensation. Okay? And I can go through a couple more of these, but I think you'll probably look at me and say, even though it's a Friday, this isn't terribly difficult, is it? Well, let me I've got one person saying, no, it's not terribly difficult. What about the rest of you? Oh dear, we're not doing well. Am I being presumptive? Is it really hard? Tell me, you're the officer. He Even the president won't commit. Let's do the next one. All right, 7.3. Acid, right? Do you want me to put the normals in? 7.4, 40, and about 25. So, 7.3 is acid. PCO2 is 70. Acid, yes. Bicarbonate, 35. Alkali. So again, the two that match is these two. So it's a respiratory acidosis with, it looks like, substantial compensation by the kidney, the metabolic side of it. Okay, pretty simple. So the other two sets of numbers are exactly the same, except that they're reversed. They're alkaloses. Do I need to go through them? No. Okay, good. So, and you could take these numbers and you could plot them on here, because I actually use numbers that kind of mesh well with here, okay? So having said all that, you know, it's obvious that you guys have found acid-base balance a little tricky, but in terms of things that you absolutely have to be able to do is analyze blood gases, and that part is actually not too difficult, is it? Okay, I mean, we'll talk a little bit more around that and what we might do in some marginal situations, but the basic reading is pretty straightforward. So on the next page, I've got some highlighted, I've got a highlighted table, and I'll just go through the first one. So it says that, just to make things easy, that whatever the primary defect is, for the compensation, the bicarbonate goes in exactly the same direction. So let's just do that for whatever the first one is. It's a metabolic acidosis. Okay. So with a metabolic acidosis, you got a lot of acid. It mops up the bicarbonate and goes in this direction. So bicarbonate's low in a metabolic acidosis. So how do you fix that? The respiratory system needs to generate carbon dioxide to counter, I'm sorry, it needs to, we're doing a metabolic acidosis, aren't we? Yeah, so you realize I had it the wrong way around, yes? So it's a metabolic acidosis, the bicarbonate goes down, and we fix it by blowing off CO2, so hyperventilating. And I apologize, I had it the wrong way around. So, so the way to get rid of the acid is to blow off this, essentially, this acid gas. But what will happen to the bicarbonate as you blow off this CO2? Go down further, won't it? So in the first place it went down because we went in this direction. And then when you blow off CO2, it goes down even further. And you can do that for all four of these acid-base disturbances, and you'll find that the bicarbonate, for the primary problem, always goes in the same direction as the compensation. And that might be helpful for you when you're trying to analyze blood gases. It seems kind of counterintuitive, but maybe that helps. Okay, so I've got a statement right underneath. There's kind of a preset expectation for compensation. For example, if we get to this point acutely, pretty much we expect to compensate that amount. And so if you ended up here, and I'll pick up my green pen, if you ended up there on the green cross that I've just put up, what would you say? You have incomplete compensation, yes? And I know that clinically, and Costanzo might say, well, that's not a simple acid-base disorder because the compensation's incomplete, so there must be something wrong with the other system. It could just be time. So if I, what is this, a respiratory acidosis? If I pop that pill, that opiate, it would take time to develop that. So it may just be a matter of time. But if after a couple of days I stayed here and had incomplete compensation, you might just assume that there was something wrong with my kidneys as well. You got that? So that's the difference between a simple disorder has the appropriate amount of compensation, and a more complex disorder is when they don't. And I've got an example of that. So, case 21. A 58-year-old man with a history of chronic bronchitis develops severe diarrhea caused by colitis. The volume of diarrheal fluid is currently about 1 liter an hour, and the illness is in its 4th day. So the arterial pH is 7.0. 7.0 is not compatible with life. We need to deal with this. Okay, well, can we do this sort of thing? PCO2 is 40, so it's not that right. Bicarbonate is 9, so it looks like a metabolic acidosis, right? Everybody seeing that? Metabolic acidosis? But is it that simple? This is in its 4th day. The lungs should have compensated by now, okay? But if you look back at the history, chronic bronchitis. So he's basically got 2 defects. He does have an acidosis caused by the diarrhea, but he also has a respiratory issue where he cannot hyperventilate enough to blow it off. Okay, so hence not a simple condition, and the way most people argue it is there's 2 defects there. Even though the PCO2 is normal, it shouldn't be normal. Okay. Any questions on that? Okay. So let's just explore these conditions, the respiratory conditions and the metabolic conditions. And respiratory, acidosis and alkalosis. And apart from the one that we mentioned, opiates, I'm not going to write any of the others on the board, but let's just play a little and see if you can come up with any other causes. Let's start with the respiratory acidosis. Asthma, good. I said I wasn't going to write it up on the board, right? Asthma, yes. Anything else? Altitude sickness, no. Well, no. Yeah. So altitude, if I'm reading you correctly, the normal response to altitude is to breathe more. Okay. Are you? Okay. However, goes down there. Anything else? I said I wouldn't write it up on the board. I am just so unreliable. Anything else?
What about emphysema?
Emphysema, yeah. COPD. basically any kind of lung condition that affects your breathing can possibly cause the respiratory acidosis. Yes. Okay. Sleep apnea. What else? I think I wrote one more thing down. Oh yeah, couple actually. Obesity, difficulty moving the diaphragm, and I hope actually look this one up, scoliosis. So anything that affects your ability to breathe, scoliosis may be one of them. What about alkalosis? We've already got altitude. What else? Anxiety. You don't need any more, do you? Okay. Good. What else? Fever, maybe. And one other I've got here is severe anemia. So, yeah. So there are a number of conditions that might, and I know you're very test-oriented right now. I'm not going to test you on those conditions, okay? So it's just that if we're talking about respiratory acidosis and alkalosis, it kind of might be nice to know some of the things that cause them. Okay. And I hope you wouldn't tell me that if it's not testable, you don't need to hear about it. You wouldn't say such a thing, would you? Never. Good. Okay, let's talk about metabolic acidosis. We are now on page 4. Okay. And we're going to talk about anion gap. And anion gap is such an idiot simple concept that it actually confuses people. So I have seen so many people try to explain this and really struggle to make it obvious. So let me take it step by step and take it slowly. If you measure sodium, it's usually about 140. If you measure chloride, and I think the figure that I've got listed is about, I think it's 104. It varies from lab to lab, 104. And bicarbonate, 28. And bear in mind that it's different from the 25 we have here because, first of all, it's venous that we're measuring, which is going to be a little bit different, and added to which the Henderson-Hasselbalch equation probably doesn't give a totally faithful number. So, what, 28? 28. Okay. Now, we know from chemistry that all the pluses must balance all the minuses, right? And so, that's got to be something else. So let's consider a metabolic acidosis. The one thing that has to happen in a metabolic acidosis is the bicarbonate goes down. But we can't violate this law of electroneutrality, so we have to have more negative ions from somewhere to replace them. And you've basically got two places to replace them. You can replace with chloride or this other stuff. Okay? So anytime you have a metabolic acidosis and the bicarbonate goes down, something else has to go up. And the reason why we make a big deal of this is that it's actually a useful diagnostic tool because approximately half of the metabolic acidoses are hyperchloremic. In other words, the chlorine fills the gap, and about half of them are not, and something else fills the gap. Okay? Oh, the anion gap, we'll call it. Okay? So this is the anion gap. In other words, all it says is it's all the ions that we never measured, all the anions that we never measured. Okay. So if we look at the table down below, and let me start off at the right. There's a mnemonic for this when you get out into the clinics, but I don't think we need to worry about that for right now. What I have done there is I've listed the things that I think that an M1 or an M2 going for step exams probably absolutely has to know in terms of anion gap and acidosis. It's not a complete list, obviously, but I think these are the ones that are most important. So on the right, diarrhea, carbonic anhydrase inhibitors, renal tubular acidosis, and ammonium chloride. Okay, those are all hyperchloremic, typically. On the left are those that have an increased anion gap. And I could write them up, but they're on the handout. So, diabetes, what's in the gap? Glucose? No, it's not charged. Who? Keto acids? Is that what you said?
I'm okay.
You are? But you might need to share it with RJ. She's hungry. Lactic acidosis. What's the anion? Yeah. Wow. Are they two easy questions?
She got it right.
Did she? There's nothing much left. Okay. And chronic renal failure, usually sulfate, phosphates, alcohol, actually that causes ketosis, so keto acids, ethylene glycol, and salicylate, okay? And this is something that the boards sometimes test you on. I guess salicylates are a favorite. I've got a little note there. It often starts as a respiratory alkalosis, and then it becomes a increased anion gap acidosis. Okay, so it goes through a phase. The one thing that I have to leave you with, though, is that in general terms we have an increased anion gap or a normal anion gap. It is not low. Okay, so don't ever say it's a low anion gap. It's either high or normal. Okay, and if it's normal, it's hyperchloremic. Okay, so and the only reason you should know this is because it helps in the diagnosis. Well, it should. Let's see. Next case. Page 5. It's the same case. Okay, so let's look back at those numbers. So this is the man that had the bronchitis and the colitis. Well, we know he's got a metabolic acidosis, and so is it an increased anion gap or is it not? Well, looks like it's hyperchloremic, doesn't it? Go ahead and calculate the anion gap anyway. Who's the first? Who's the first? 17. Who said 17? Did you do that without a calculator? Darn, you're amazing. You know, when I was your age, we didn't have calculators. Yes, ma'am.
What's
Oh, that's a good question. What does it say in the handout? I think I made it an option, didn't I? Okay, and it's a good question. Some labs use potassium and some don't. But the point is, if you do or you don't, you have to adjust your normals accordingly. Okay, I think most labs do not include potassium.
So the one with potassium is more support information.
Say again?
So we wouldn't be including potassium if we were calculating.
Oh, yeah. For here, but if you did include potassium and you got a different number, you were also correct. Okay? But yeah, usually I think most people do not use potassium. You could certainly make a case, well, you should. So it looks like wait a minute. Didn't we just say it was hyperchloremic? But now I'm telling you it's an increased anion gap. Okay, we've just added a layer of complexity. I mean, in this particular case, this person's probably so dehydrated and having trouble breathing that the metabolism was affected, and he may have a superimposed lactic acidosis. The diarrhea you would expect to cause a hyperchloremic. And there's certainly some indication of that. But the increased anion gap is actually an unexpected finding. And it's probably because of the severe metabolic issue and getting a superimposed lactic acidosis, which can happen when a person's compromised metabolically. Okay? Straightforward? Are there any other questions there? Oh, yeah. So, I'm looking for a doctor when you graduate. So this patient's given sodium bicarbonate. What do you think might happen to the potassium?
Go down.
Yeah, go down. Let me write your name down. I'm ready to. Will you see me in about 5 years' time? No! No! Do you think I'm going to be one of those difficult patients?
Maybe.
Oh, gee, give me a break. Oh dear, what a meanie. So remember that acid-base balance tends to affect potassium. If you have an acidosis, it tends to move potassium out of the ECF or out of the plasma. So if you give bicarbonate, it goes the reverse way. Okay. So did I say? Oh, yeah. Okay. So if you give bicarbonate, it'll tend to move potassium into the cell. And so you could, if you have a potassium, oh, look, this guy's got potassium depletion. You're going to have to think really hard about giving him bicarbonate. Actually, bicarbonate's called for because he's losing bicarbonate, and if we don't do something, he could die. But we've really got to pay attention to that potassium, okay? So, yes, ma'am.
Can you explain the potassium one more time?
Yeah, sure. And this is always done in very simple terms, and it may be, there are more layers to it than this, but this is the simple explanation that's used. It's used in textbooks, and it's fine. So if you have an acidosis, the acid goes into the cells effectively, and the potassium comes out. Okay? It mostly doesn't go in directly, but that's kind of the idea. And so if you give bicarbonate, it'll flip-flop in the other direction. Okay? All right. I've got a point there. Bicarbonate's not always a magic bullet. It it turned out that in some cases that when you gave bicarbonate, survival rates were not necessarily very good. Now, if you got something like diarrhea and there's a clear bicarbonate loss, replenishing the bicarbonate usually does fine. But in certain other conditions like diabetic ketoacidosis, there were some poor outcomes. So having done this, let's use this. Where's my... So that's the situation. So if we've got too much of this guy, we give bicarbonate, which mops up this and fixes the acidosis. And that's a good thing, yeah? So, but the problem is, when we give the bicarbonate and fix the acidosis, we go in this direction. The bicarbonate doesn't go into the cell directly, and so you have a tendency to do that. And so you may actually get a paradoxic acidosis inside the cell. And that's considered to be one of the reasons why bicarbonate administration under some circumstances can be a bit dodgy. Because although it fixes the extracellular, the poor outcomes may be related to the fact that you have this paradoxic shift. Okay? The point, though, is that from a clinical standpoint, you cannot keep somebody at a pH of 7.0. And so the idea is at pH 7, this is critical. And one of the things is that it tends to cause cardiac arrhythmias. And so you kind of need to get them away from 7.0, and if you can pull them back to about 7.2, then the dangers of a cardiac arrhythmia go down. And so the conventional wisdom is, yeah, it may screw the patient up a little bit and cause a paradoxic shift, but if we do it slowly, we kind of need to get back to a pH of 7.2. And then the patient is relatively safe. Okay. Any questions on that page? Yes, ma'am.
Okay, back to the anion gap. You said 17 was indicative of increase.
Yeah. Oh, I didn't give you the normals, did I? Darn. About 8, between 5 and 11. I am so sorry. That's a really good question. Where's?
0 to 10. Where's the discrepancy? Or is that like?
Say what? 0 to 10?
Well, I looked at.
Where did you get that from? Well,
Medical website. Is it like every lab is different?
yeah. Is it like every lab is different? Yeah. Thank you for so much. That's all you got? Cookies? No good, huh? Picky, 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 picky. There are raisins in them, I think. Yeah, labs are different. For example, for the values I gave you, 104 is the normal for chloride, and usually chloride's a little bit lower than that. So, yeah, lab differences.
5 to 8.
About 8, 5 to 11. I think, it is kind of important to get it from the same source, and I actually wrote down, I think it was 5 to 11. Yeah, so I gave you normals of 140 for sodium, 28 for the bicarbonate, 104 for the chloride, and under those conditions, which is kind of normal, it's about 8, and so they give a range of 5 to 11, okay? But it is true that some labs may be a bit lower on those anions.
Well, if they use like dicarb 22 to 26, I guess it would make it lower instead of 28.
Oh yeah, well,
Those values as well.
yeah, yeah. It is true that different labs, different results. Okay, let me try and move through this fairly quickly then, because I guess because we didn't get started on Wednesday, we're probably running a little bit behind. So what causes an alkalosis? Metabolic alkalosis. Basically, there are a lot more things than what I have in this table, but I wanted to divide them up into things that are basically contraction related and things that aren't contraction related. If you get if you have a loss in plasma volume, here we are in the proximal tube, you'll get a loss of plasma volume. You really crank up this guy, and so you can actually get an alkalosis associated with contraction. Okay? And in those cases, you can usually fix the problem by fixing the dehydration or contraction. Okay? And I'm not going to write these up for if it's not a contraction. The options you have are carbonic anhydrase inhibitors. I don't think you need to write these down, okay? Dialyze against low bicarbonate, or give an acid type compound, and I won't even describe what they are right now. Okay. Let me skip the case 19, which I should have relabeled 23. But let me just give you a hint as to where this is going. This is a person that gets dehydrated, and after 12 hours, he's got a classic situation of a contraction alkalosis. His pH is alkalotic. His PCO2 is trying to compensate. And his urine pH is 7.5. In other words, he's peeing out. He's peeing out bicarbonate. At 60 hours, the situations are getting worse, and he can't make alkaline pH. In other words, as his contraction gets worse, he can't pee out the bicarbonate because that sodium pump, that sodium pump is working really hard and reabsorbing bicarbonate just so as it can reabsorb sodium. Okay. So am I going too quickly on this? I'm trying to move through this quickly because I want to go ahead and get the review done before lunch. Does that sound like a good plan? Okay. Okay. All right. Base excess. Okay. Rather than go through that as it is, if you have a metabolic problem, you either need to give back acid or base. Okay? So how much do you give? We can actually determine from the Henderson-Hasselbalch equation how low you are on base. But remember, first of all, we've got to eliminate bicarbonate due to respiration, so we have to correct everything back to a PCO2 of 40, and we have to account for other buffers, and then we can make a determination as to how much acid or alkali that we need to give back. Okay? And base excess is just a simple expression of how much base you'd have to take away or give back. Base excess, you'd obviously have to take it away. If you have a negative base excess or a base deficit, you'd have to add bicarbonate. And so in quantitative terms, it's also a reflection of the metabolic status of a person. Okay, and let's go through some examples. I think at the bottom of the page, okay, question. So, let's have an acute respiratory acidosis. I think this was it, wasn't it? Yeah, here we go. Acute respiratory acidosis. What's the base excess at this point? It's 0, because this is a pure respiratory problem and there is no metabolic component. Okay. Now, when you go over here, you're effectively making a metabolic alkalosis to try to compensate for it, and you would actually then have a positive base excess. Okay, let me go through that again because I think that may be confusing. So you just have a respiratory acidosis, you get too much CO2 on board, and no matter how much CO2 you get on board, if nothing else happens, there is no base excess, because remember, it's defined as the non-respiratory bicarbonate. Okay, but now when we compensate, how do we compensate for a respiratory acidosis? The kidneys will add bicarbonate, so they will generate a base excess to try to compensate. And that's, okay, it's not strictly speaking bicarbonate, but it's a kind of a modified expression of bicarbonate and other bases. I think that if you read that page after what I've said, it may help you out. But I tell you what, let's why don't we just go through some examples here where I've added the base excess and see if it all now makes sense. Let's look at the second one first, because it's a fairly straightforward case. So this is, the pH is 7.025. Acid, yes? The PCO2 is 24.9. Alkali, yes? Did I take the bicarbonate out? Oh no, the bicarbonate's 6.6. Acid. So just about anybody can figure out that this is a metabolic acidosis with respiratory compensation. So what might we predict the base excess is? If it's a metabolic acidosis, there should be a large negative base excess, negative, or a base deficit. So, and sure enough, if you look at the line up from 6.6, you've got a base excess of minus 22.4. And that's so that the physician can now give the appropriate amount of bicarbonate back to bring it back to knows how much base is deficient and knows how much he wants to give back. Straightforward. So for me, I can work it out by looking at the bicarbonate, but that base excess is actually kind of a powerful part of my analytical tools. Okay, let's do the next one along, which is pH 7.307, the third one. So the third one is, it's an acidosis, right? PCO2 is 55.5. So it's looking like a respiratory acidosis. So what might we expect the bicarbonate to be? 27.9. I'm a bit confused. Now it's 27.9. Okay, so I've got extra CO2. Is that 27.9 due to the added CO2 or not? Or is there any metabolic bicarbonate there? And so when I look at the base excess is within normal range. It's actually +1. And now I can say, well, that is due just to the that's just the respiratory bicarbonate. Have I confused anybody? I'd be happy to. Should I try again or try again? Okay. So we know we have a respiratory acidosis. My question is if I've got a respiratory acidosis and it's going in this direction to make acid, how much do I expect the bicarbonate to go up? So is that bicarbonate of 27.9, is that just due to the fact that I've accumulated CO2? Or is there a metabolic component to it too? And so if I look at the base excess, I see the base excess is close to 0. And so this is entirely a CO2 effect. And there's no metabolic compensation. Okay? For whatever reason. It may not have had time to develop, but there is no metabolic compensation. Yes, ma'am? I think it says +2 to -2. Can you read that there? Yeah, +2 to -2. Okay. Do you want to go through another one or not? One more? Okay. Let's do the first one. So pH of 7.394. Okay, this is actually within the normal range, so we can all go home, right? Well, yeah, I mean, probably the physician is not going to get terribly excited about it. So probably the PCO2 is normal and the bicarbonate's normal, right? Well, but it isn't. So let's see if you can be sharp about this. The PCO2 looks like it's making acid, and the bicarbonate's kind of high, but that PCO2 is not causing that bicarbonate to go up that much. So do we have a respiratory acidosis and a metabolic alkalosis making everything right again? I bet this person's on a ventilator, by the way, and that may explain the issue. Well, if you look at the base excess, there is excess base there, and so indeed this patient has a little bit of a respiratory acidosis and a little bit of a metabolic alkalosis, which just happen to balance each other out. So I wouldn't get terribly excited about it, but I might want to monitor this patient and see if either one of these conditions gets worse.
So would this be two separate conditions, or would this be compensation?
Well, the question is, would this be two separate conditions, or would it be compensation? And that's a hard one to say. Compensation shouldn't usually bring you back to pH normal. Okay, so it certainly isn't a normal compensation. And you really can't tell from this stage exactly what's going on. But this could be a person that's in a metabolic alkalosis, and then they reduce the ventilation, or at least they reduce the ventilation to try to get the CO2 up. So it could be, it's hard to tell what it is, but likely two different defects. Okay, so work with these a little bit, and I'm sorry we went a little over. I'm sorry I rushed towards the end, but I did kind of want to go through quickly the review after a break, and then I'd be happy to answer more questions afterwards. Does that sound like a plan? Okay, let's take a break and we'll set up a review and I'll try to go through that real quickly. Okay? Yes, sir. Yeah, we're going to record the review, aren't we, Jerry? Yeah. Yeah.